Welcome to ICE Webinars, a cool place for hot topics. ICE Magazine is proud to bring our monthly webinar series to the imaging industry. ICE is the community that directly links nearly 7,000 imaging professionals with a monthly magazine, online community, annual conference, and now a monthly webinar series. ICE Webinars would like to thank our sponsor, Accruent. Accruent is the world's leading provider of intelligence solutions for the built environment, serving more than 10,000 customers in more than 150 countries. Their solutions improve operational efficiency, regulatory compliance, and the quality of patient care, and drive gains in performance and availability of healthcare assets, including facility and biomedical equipment. For more information, please visit accruent.com. We're excited about today's presentation featuring Al Gresch, Vice President of Healthcare Strategy at Accruent, and Pat Trim, Supply Chain Consultant. They will show participants a better way to optimize capital spending and avoid unnecessary expenses with a comprehensive technology assessment program. Today's webinar is eligible for one ARRT Category A Continuing Education Credit by AHRA. You can obtain your continuing education certificate by completing the post-webinar survey. More details on this at the end of today's webinar. We'll wrap up today's presentation with a live Q&A. You can submit your questions at any time using the questions feature on the webinar dashboard. We'll get through as many questions as time allows. As I mentioned earlier, today our presenters are Al Gresch and Pat Trim. Al, you may begin whenever you are ready.
Thank you, Jennifer, and thank you participants for joining us today. Our agenda for today is we're going to talk about why it's important to have a technology assessment program. My partner in crime, Pat, will talk about how to successfully convey the benefits of the program to hospital leadership and justify the technology assessment position. We'll talk about how to develop and structure a successful technology assessment program. And then finally, we'll talk about real-life results from having a director of technology position in place. So let's jump in. Why is it important to have a technology assessment program? So if you look at the typical capital asset lifecycle process, there's four quadrants of it, if you will. There's pre-assessment, there's the acquisition phase, support, and final disposition. If you look at what typically happens in the pre-assessment phase, it starts out with the budget process. So looking at how much money do we have to spend, and then once that's determined, then the dollars are typically broken up into three buckets: recurring capital or replacement capital, strategic capital, or contingency capital. And the issue with that is if you're not doing a great job of pre-planning, often there's a very low level of confidence with the CFO that the right decisions are being made for the right reasons, and subsequently that contingency bucket is bigger than it needs to be. So then it goes into the capital planning phase, and my own experience with this, working in healthcare organizations, as well as talking with a number of our customers over the years, is pretty similar. It starts out with what we refer to as the wish lists. You put in a list of things that you wish for, and then you wish that you get them approved. And then if you incorporate a tool like Strata or Kaufman Hall, it's more or less a repository for all of those requests, and gives the finance folks a way to review what's there, review the justifications that are provided with them. But there's really no prioritization methodology based on objective criteria. And then it goes to the capital approvals process. And in some organizations, they have a capital committee. Not all do. In some organizations that I've spoken to, the CFO is the guy making the decisions about what gets purchased. And then again, it comes down to who makes the best justification, or often it's the squeaky wheel gets the grease, right? Whoever yells the loudest is the one who gets the money. And so once that process is completed and determinations are made about what is going to get purchased in any given capital year, and my experience has been that the number of requests exceed the amount of available capital by 3 to 4x, and sometimes even more than that. So once those decisions are made, then typically that'll be broken out into quarters throughout the year when those purchases will be made. And then it gets passed on to capital acquisitions. You think about what that group is incentivized by. It's to achieve the lowest acquisition price, not necessarily the lowest total cost of ownership throughout the life cycle of that equipment. What does that result in? A lot of times it results in increased downtime if you're not making the right choices about what equipment to buy. It's just solely based on lowest acquisition cost. When you have increased downtime, it impacts your staff productivity and increases your service costs. So there's a lot of unnecessary expense associated with that if you aren't doing things the right way. Once the equipment is acquired, then it moves into the support phase. In the installation phase is where often there are problems that are encountered, especially with the larger capital, what we refer to often as the big iron. So the RNF, rad rooms, CTs, MRIs, things like that. And if there isn't some comprehensive pre-planning that goes into it, oftentimes these things will show up. You'll find that they don't have the appropriate power or networking or HVAC. And so not only does it delay the project, but there are ancillary costs associated with that. And where do those dollars come from? Well, they either come from contingency funds that were set aside, which reduces what you can actually acquire throughout the year, or it comes from operating costs or your operating budgets. And I'll tell you, in my experience, most department leaders are on a bonus program, and their bonus is tied to hitting budget. And so clearly, those folks aren't happy when these unseen expenses come out of the blue and makes it near impossible for them to hit their budgets. Then we move to the device repair and analysis phase, and this is, the service that's completed throughout the life cycle of that equipment. And what I've seen is that many organizations in the clinical engineering groups, they lack clean, standardized data, and the price for that is, it makes it difficult to make those good decisions when you haven't captured the good data. So there's inconsistency around things like manufacturer, model, device category, so that running reports is difficult to get good, meaningful decision-making information from. But just even the codes within the database of how people are documenting things makes it difficult to ascertain what's actually going on and make good decisions from it. In the materials management part of the support phase, often what I've seen is that technicians are tasked with purchasing parts, both for planned maintenance, so things like PM kits, and repair parts. And when that isn't centralized, and you're leaving it to each individual to do that on their own, there's a significant lack of consistency and quality, as well as consistency in pricing throughout that process. In addition to that, the average annual device hours per technician in the healthcare technology management industry is about 1,000. So if you think about that, less than half of the time that you're paying this person to do a certain job is spent actually doing that job. So there are a lot of unnecessary costs and time spent around that. And then the last is disposal. How does that typically work? Well, in some instances, there's a trade-in that's offered on that equipment, and very often those trade-ins you're getting pennies on the dollar for what that equipment is actually worth. When there aren't trade-ins offered, then often it'll either go into a storage room somewhere. It could go into a dumpster, and if it does, or even if it is sold, is there a process in place to make sure that the PSI has been removed from the device, or any hazardous materials that might exist on that device have been removed? So there's just a lot of risk associated with what typically goes on in this process. So let's move to what an ideal capital asset lifecycle process would look like. And the first part of it in the pre-assessment is primarily what we're going to talk about today: the technology assessment, project planning, and equipment analysis. And Patrick is going to take us through some significant detail on this, but I'll just touch on it on a high level. A good pre-assessment process will include researching breakthrough technologies, specification pre-planning with the department prior to budget time, a review of past equipment performance data. Are there things that we should steer clear of because they've been a maintenance nightmare for us? The technology director then, once completes his review and analysis, can integrate the SOW, or statement of work, and deliverables into a document for procurement, so that they know exactly what it is that they should buy and how much of it they should buy. That person, that technology director, matches clinical application to the equipment, and they spec that at the time of purchase to prevent over or under buying. Often that's left to the original equipment manufacturer to make recommendations on what you need. If you think about what they're incentivized to do, it's to sell as much as they possibly can. Well, are you actually going to use those bells and whistles, the features and functionality that they're trying to sell you? So that's part of this role, is to help determine, in working with the department, what they actually need. And so you'll see the statement there in the upper right that says you have the opportunity to make better buying decisions based on actual clinical need and objective data. A couple of other things that this does is, they'll be involved in equipment project planning for large construction projects and capturing the costs associated with that, and also provide the opportunity to build out a 5-year future equipment plan. That gives a procurement group so much leverage and an opportunity to save money. So then if we move into the ideal acquisition part of this cycle, again, they're starting out with a recommendation of things to consider for capital replacement based on objective criteria. Things like, age and service expense and service trends, end of life information, regulatory information. And so there's a list of objective criteria that acts as a starting point for considering things for capital replacement. As I alluded to earlier, many CFOs have very low confidence that they're making the right replacement decisions for the right reasons. Procurement will partner with the vendor, the technology director, and the department to finalize the scope and deliverables of the project, and that will go into their contract negotiations. They'll develop an RFP and negotiate and leverage strategy to include things like training schools, parts discounts, time and materials labor rate discounts, warranty extensions, warranty start dates. I don't know if you realize this, but most warranty clocks start the day that device leaves the vendor's dock. Okay, imagine if you've got equipment that you purchased for a project that could sit in storage at your facility for sometimes months, and that whole time the clock's ticking on the warranty. They can also negotiate timelines around the installation, and if there's something that you don't feel that your clinical engineering group is going to be able to support in-house, to use that opportunity to negotiate point of sale service contracts. But the thing I want to make clear here is that all of that those are all things that you have the most leverage when you've still got those capital dollars in hand. As soon as those dollars pass on to the vendor, you leave it to the clinical engineering group to negotiate those things, or some other contracting group to try and negotiate those things after those capital dollars are gone. You're just not going to have the same amount of leverage. And then it'll go through go into the actual capital acquisition phase, and there too they'll validate capital purchase with facilities and construction. They'll work with IT and clinical engineering to be sure that all costs and operational considerations are taken into account. And then communicate the final purchase information to all of the parties in regard to expected receipt, timeline for installation, deliverables that were contractually agreed to. And what it says here is they understand and drive down the total cost of ownership, not just work to get the best acquisition cost. And then as you move into the support part of this, the first part of this is receiving. So here, if it's set up correctly, the support department will actually do the receiving. Often that is simply a box counting exercise if the distribution group is checking those things in, and they have no way of knowing whether or not everything that was ordered was received. So the best practice process is to give the support group access to your MMIS, or materials management information system, to receive those things in, where they can actually validate that what was ordered was in fact received. And then they also use the documents that were created by procurement to make sure that the device is accepted appropriately according to the specifications that were laid out in the contract. And the other thing that this does is makes sure that equipment is received and safety tested before it goes into use. I've done consulting with a number of healthcare organizations and found as many as 15 different ports of entry into the organization for equipment, many of which don't find their way to folks like clinical engineering to make sure that those tests are done. That creates a significant risk for the organization. And then the next part of this is, once the installation and acceptance testing is completed, it triggers that back payment. And if it's something that you've leased, then that's when you would start the lease payments. But even if it's something that's purchased, often there's the terms will include a back end payment, and you're making sure again that you're maintaining leverage by holding back that last payment until everything is as it's supposed to be. And then, of course, you move into the device repair and analysis. But if that's being done well, now you can effectively do the repair versus replace, make those repair versus replace decisions based on the data that you've collected. If you centralize your procurement, your parts procurement, you can leverage volume. Often what we would do is make a determination as to what PM kits were needed for the entire year and purchase them all at once and leverage that volume to get the unit pricing down. The other thing that does is, technicians are busy. They often have more to do in a given day than time to do it, and so oftentimes they'll forget to order those PM kits, and then you put them at risk for not completing their PMs in the month that they've been assigned, and so you'll order things overnight and increase your shipping costs associated with those parts. So I mean, there's just a number of reasons why that's a good practice. And then service contract and lease centralization, having that in aggregated so that you can leverage volume. So all of the devices that are with a specific vendor, to aggregate those into a single contract, and you can leverage volume. Or if you've got a number of different devices, there are many OEM service organizations that provide multi-vendor service, and so GE can often service Philips ultrasounds as well as their own, or Siemens ultrasounds, and if you aggregate that volume to one service provider, you can drive your costs down. And then asset management. I've often felt that included in the support of equipment is also getting the equipment where it's needed, when it's needed. And so the equipment distribution management should be part of that support life cycle as well. And then you get back to asset replacement planning and making decisions about what to replace based on objective criteria. And then in the final disposition, the reporting and analytics to determine the best disposition option. Doing good management of unutilized or underutilized capital assets can save you millions of dollars. We did that in a couple of different organizations. That's a whole separate presentation in and of itself that we could do and probably will do at some point. But you really maximize the dollar value of assets through a well-defined process, matching trade-in offers to fair market value, and then use that to determine auction potential, and also prioritize disposition. Our first prioritization was always reallocation of devices within the system. It's shocking to me how often an organization or a department will put in a request for a piece of capital when there's half a dozen of them sitting in a closet that no one's aware of. And then the next prioritization was either auction or sale, trade in if that's the best option, parts harvesting if that's the best option, or donation. But I mean, you're leveraging KPIs for continuous improvement and cost reduction, and then it takes you right back to where it all starts, which is having a comprehensive technology assessment program. So with that, I'll let Patrick talk about how to successfully convey the benefits of the program to hospital leadership and justify the technology assessment position. Well, Pat?
Hey, thanks, Al. Appreciate it. Good afternoon, everyone. I think Al did a really good job in kind of outlining the structure that's necessary to support a technology director position. I want to get down into the nitty-gritty a little bit and talk about the technology assessment program justification. It's very difficult sometimes when you're working with CEOs and CFOs because they take a myopic view of, either finance or a very high level overview of operations. So it's important to do a lot of pre-work in order to justify this position. Because the worst thing you could do is go into their office with a little bit of analysis and say, hey, I think we need a technology program. Here's why I think we need to do it. I did that once and got laughed out of the office. So it allowed me to go back and kind of think of, and I learned from the CFOs. I mean, they didn't laugh me out of the office as much as they gave me a lesson and said, hey, if you want to, support this type of position, you're going to have to provide X, Y, and Z. So let me run through, having put this in 3 different organizations, let me kind of run through what's really worked for me in larger organizations in terms of justifying this position. The first thing, and I can't stress this enough, is going to the stakeholders and getting their buy-in first, because I found out what the CEO and CFO typically do when you bring it to them is they'll pick up the phone and call the director of radiology and say, do you know anything about this? The last thing you want is a director of radiology going, no, it sounds good, but I don't know anything about this. That's going to set the program back big time, and it's going to kind of hurt your credibility a little bit. So it's very important to build that justification around stakeholders, everybody that has a piece of this, and sit down and talk to them and outline the program to them. You don't have to get a full commitment, but just so they know what's going on, what you're going after, and they give you, yeah, this sounds like a great idea. The next thing, if you're in a larger hospital, there's service line committees. Now, service lines, as a lot of you know, are being developed in a lot of hospitals, and they're more operational focused. So you have a director of radiology or VP of radiology sitting on a committee looking at operational efficiencies and those type of things. They also want to look at these type of ideas because they're incentivized, like Al was saying with the CEO and CFO on the budgets. These folks are incentivized by how much they can save, what their operational efficiencies look like. So to present these type of ideas to those committees, if they have one, can speed up this process tremendously. The next step would be to develop, once you get that buy-in, to develop the value prop, right? And look at the existing or current capital budget. You have, I'm sure, buying trends of what you've purchased in the past, in radiology, cath lab, OR, and what accessories you purchased and those type of things. It's important to use real life examples to illustrate those. So, if you are looking at a rad room or a CT or an MR, what typically have you purchased in the past? What type of accessories? What have the physicians, radiology docs looked at and said, hey, this is what I want? So everybody knows on this call there's a difference between want and need, right? And we tend to focus in the hospital industry on want. Because the capital budgets are so tight, we're thinking, hey, we've got to get as much as we can. But sometimes, as Al pointed out, we tend to overbuy in those situations, and we buy, based on a what if. What if I were to expand this program? I'd need this information, or I'd need this software, I'd need this whatever. So I want to buy it now. That's where this program with a technology director comes in. They can work with the radiology director, OR director, the physicians, to really develop what's needed and to make sure that this equipment is scalable for the future use. So if they are going to develop a program, let's make sure this equipment is scalable so that we can add on in the future and we don't have to expend the money now. So part of the analysis is to look at, hey, this is our current buying trends. This is actually what we could get away with. This is actually what we need. And Al will illustrate later on what that savings look like just by putting that program in place. We have some real life examples, but that's the analysis you have to go through. because you can eliminate costs for over purchases of a lot of things, right? When you look at it on a needs basis. Once you have all this information in the buy-in, it's important to build a business case for the CEO and CFO. This is the point where you want to go to them now that you've greased the skids with your stakeholders. You've really looked at real life information and compared it to information that, you know, where it could be, and the savings associated with it. What I have found in the past, CFOs, and I was one in the past, and this is what I, you know, ask of our radiology group and OR group, is to make sure that we're buying smart, and the CFO is going to, you know, stress that there's a very tight capital budget. This plays right into, yeah, we know you have a tight capital budget. Honestly, if we can institute this program, we can actually go down the list of capital that we couldn't afford and actually afford some of that capital. And that really piques their interest, especially at the hospitals, the CFOs and the CEOs at the hospital level. And I would recommend going to those folks before going to corporate. Al, next slide. So once you get this approved and you get the buy off, the committee formation is very important. I have put down typically on this slide who I have on the committee. And I'm going to point out a couple different positions here that are extremely important to have. One is the chief medical officer, the CMO. If your institution has a CMO, they're usually incentivized by medical innovation and medical results, but they're also incentivized by savings. So having a CMO who the physicians would respect is a very key player in this committee. The other key player from a finance side would be finance, of course, but also the reimbursement specialist. Because once you can tie numbers to a cost that's pre-negotiated, you can show the benefit of this is what it would have been versus this is what we came up with. Now, promoting this committee would also promote the technology assessment director, because there's a lot of pre-work, and as you can see on the bullet, advanced research on upcoming capital emerging technologies performed prior to this core committee group. It's very important to come armed with all the information you have from a reimbursement, from a finance, getting the CMO to buy in, you know, and having others on the group that are particularly invested in this technology to be part of that group as well, so that all this can be looked at, you know, vetted before it goes to finance and to the CFO for final approval. And you also want to get regional committees involved. You want to involve them to make sure that they're engaged in the process, that they're fully advised on the process, that they buy into it, and they take ownership of it. So it's very important to give them tasks from this committee to go back and report back to the committee. Next slide, Al. So on this slide is part of the analysis that this group, the pre-group, goes through in order to present it to the committee. So you've got a return on investment. Al talked about that a little bit, as well as a total cost of ownership. Those are two very important pieces to sell any technology. The return on investment obviously will show volumes related to, you know, payback and all those types of things to make sure that, you know, it makes sense to buy the equipment, right? So when you start to look at technology from a needs basis versus a wants basis, you know, the return on investment obviously is better. Total cost of ownership, that's where you pull in clinical engineering. That's where you pull in the end user. Just because something's a good value doesn't mean it's going to be good in terms of service and support during its life cycle. So it's a very important look at the equipment based on those statistics. I talked about the reimbursement analysis, and this one kind of ties into the ROI, But it even takes a deeper dive because now you have a reimbursement specialist within finance backing you up on these statistics. And those folks can really be, they're usually part of finance, and they can really add credibility to the process. I talked about equipment scalability. That's important because if you're now buying equipment based on need, you know how quick and fast things change in the healthcare industry. It's really important to have something that's scalable, so you don't have to go and buy another piece of equipment. So building in that scalability will allow you to expand that equipment capability in the future. This next bullet, extremely important. I've been at facilities where they have been burnt on this, and it's important that you have a strategic relationship with the vendor, because a piece of equipment, depending on its life cycle, it may be 2 years and they're going to sunset this thing. Now the vendor, some vendors are very honest and forthcoming, and they tell you, hey, we're coming out with something new in a couple of years. You may want to wait, or you may want to lease, or there's other options that you can look at. If you're not told this information, I've been in situations where we've purchased equipment and we find out that it's being sunsetted the next year or two, but you never want to be in that position, obviously. So it's important to have that strategic relationship to make sure that you're buying the latest and greatest, so you can get that capital life cycle, as Al pointed out, as long as you possibly can. The negotiation results. It's very important to negotiate this, as Al pointed out, prior to the purchase. You have the leverage. You have the leverage for service contracting, you have leverage for warranties. That can all be put together as a package with the rest of this analysis, so that everyone really gets the full picture of what this equipment is going to look like over its life cycle, and what we can look at in terms of the future and the volumes and the throughput and those type of things. It's very important so you can make a very informed decision. Al, next slide, please. So I'm not going to go into detail with this, but I put this in here as a total cost of ownership model. I worked with a vendor to put this together, and it was based on a lot of information on the imaging side. So you can see on the right-hand column the service costs, the in-house service and the parts. It shows imaging costs, those types of things, in-house labor costs, the percentage of total service cost to labor, and it's pretty high on this one. And then the total service cost to labor, you're spending $3,911 per year to maintain this piece of equipment. So very important information. And a lot of companies and hospital systems don't really employ this method. And wherever I've went, I've tried to employ it from the get-go, working with clinical engineering and Al's group, in order to make sure that we have a full handle on what we're looking at here in terms of cost downstream. Al, next slide, please. So this just shows a schedule. Shows downtime, average downtime, allocated space. A lot of people forget that a space in the hospital is very costly. And when you're providing service, are you getting a payback for that service? There's a lease cost if that's applicable. Utilities, there's a utility cost, obviously, to run the equipment. Salaries and wages of the employees, the consumables, the residual value of the equipment, any upgrades that may come along during those years. Next slide, Al, please. So this just kind of breaks out the purchase of the equipment. It kind of gives it kind of a, this is more of a dashboard that you're looking at. It kind of rolls up that information that you saw on the other slides, and gives a pretty good indication on your operating expenses over 5 years. So next slide, Al. This is on leased equipment. So if you want to lease, there's a lease analysis, and we could go into that in more detail, but that's kind of a session in itself. But if you're going to finance equipment, when you start to look at the monthly payments and the residual values and all those types of things, this is a good analysis to go through once you purchase the equipment, but there's also an analysis you can go through to see if leasing's the best way to acquire the equipment. Typically, it's not because you're always paying an upcharge on it. But based on cash flow, sometimes this is something that is appealing to some CFOs. Next slide, Al. So I want to talk a little bit on the next bullet here is how to develop and structure a successful technology assessment program. So Al, do you want to go to the next slide? Thank you. Here's the requirements for success. We talked about this a little bit, but you got to have administrative support. I can't emphasize that enough. And once you garner that administrative support, I have seen, dramatic savings targets being met. Obviously, you're putting yourself out there a little bit because you're promising that this is going to happen. But setting it up in this method, it's pretty much a given that you're going to save a pretty good amount of money and stretch the capital budget. The hospital level support is extremely important as well. Those are the people that really feel it. Corporate understands it, but the hospital level folks really get what you're trying to do typically. Competence and expertise. So this gets into also the third bullet in terms of trust. There's got to be trust in this program, and it's extremely important to hit your targets the first year. So I'm not saying to go really conservative on your targets because your program is not going to get sold, but you don't want to promise the world to them as well, because you're just getting the program up and running. So as long as you can show success and you can show that there's competence in your technology director, that they're getting up on the front end and talking to the stakeholders in these situations, you start to build that trust. You start, especially when you show the results, more and more, it's like a snowball effect that people are really drawn to this, and your technology director actually gets pretty much overworked. So, and then you start to have to prioritize your projects. So, negotiation skills. You're going to really need to partner with your procurement department and your supply chain folks on the contracting side to make sure those negotiations are, encompass everything that Al was talking about in terms of making sure you have the leverage, you use the leverage with the vendor to be able to get the warranties extended. The warranty, like Al talked about, doesn't start at the warehouse. It starts at the point of use and acceptance. All those things have to go into the negotiation and be done prior to making any type of commitment to the vendor. The next is consistent performance. Use the same process consistently. There's going to be times when you're going to have to deviate from the process somewhat, but when you start to do that, you start to expand the scope of the technology director's position, and it really gets to be unwieldy for that person to really maintain the integrity of that program. So creating bylaws, creating policies and procedures, and making sure that communication is out to the end users really is extremely important. And then obviously delivering that information, and then showing the reports to senior administration of the results. Use a very succinct format, a one-page format for decision making is extremely key, because as you all know, CFOs and CEOs don't have a lot of time to look at 5 or 6 different slides of all this information. They just want to know what happened. Are you producing results, and can I make further decisions on this? Next slide, Al.
Thank you, Patrick. Really appreciate you sharing that information. Lastly, we're going to talk about real-life results of having a director of technology assessment role in place. Just a reminder of what that role is. Researching breakthrough technologies, specification, pre-planning with the department, review of past equipment performance data, integration of SOW and deliverables into procurement, matching clinical application to the equipment to prevent over or under buying, and then equipment project planning for construction and project costs to minimize that. So these were just a number of examples of things that we've done in one given year. So this is at an organization that both Patrick and I worked at. So there was an fMRI need. fMRI is for brain mapping, and this position identified existing software licensing that we had already paid for to upgrade that technology. And the vendor would have otherwise willingly charged us for that, and as a result, we saved $300,000 just on that one instance. On the electroneuromag, again, right-sizing the technology, we saved $338,000 on that. Varian true beams, we bought a number of them, and it was a combination of both right-sizing that technology, but also leveraging the volume of the number of devices that we were purchasing. That brought a savings of $1.4 million. Siemens Cath Labs. I always tell this story that we had in the budget a single cath lab replacement, and I went to the system director of cardiology and I said, Noel, we've got 9 labs in the system. It's my understanding that you would want to standardize on those eventually across the system, correct? He's like, yes, absolutely. I said, great, then I'm not negotiating for a single lab, I'm negotiating for 9 labs. And again, so the leveraging of that technology position to first of all right size the technology, but then leveraging the volume of all those systems, because I made it clear to whatever vendor was going to win the business for this one was going to win it for all of them. We saved $3 million. The GE 64 slice CT is a similar thing, where both a combination of right sizing the technology for neuro and cardiac programs, as well as leveraging volume. We saved $4.5 million. So you combine all of that and think of the amount of additional capital that we were able to afford that we otherwise would not have been able to. The last thing I want to talk about here is we talked throughout the presentation about the importance of bringing to bear good data, and as I mentioned early on, a lot of organizations don't have good data to rely on, and so one of the programs that Accruent offers is called Data Insights, and we have service history and data from over 1,700 hospitals that we've aggregated, and can provide this information to organizations to help them improve their data, help them prioritize equipment replacements, help them select the best equipment based on real life service history and data about what's the most reliable equipment, how long does it typically last versus what you might get from AHA estimated useful life information. And then this is just a snapshot of the ROI for that platform, and you see a 1,900% ROI. Typically, what we see working with customers is they'll get between 1,500 and 2,000% ROI with several $1 million in benefits. And those savings come from a better capital process, reduced time spent on planning capital, but also understanding what is the best price that I could get or that I could pay for this thing. having visibility into all assets and where they are in their life cycle. I cited the instance of what we did with the cath labs, and if you had that level of visibility across every device in your inventory, imagine what kind of leverage that would give you from a negotiating perspective. And then lower support costs by making better decisions about what equipment to buy. So that's Jennifer, that brings us to Q&A.
Thank you, Al and Pat, for a great presentation. As a reminder to the audience, if you do have a question for our presenters, please use the question feature on the webinar dashboard. We do have some questions that have come in already, so we'll start with those. Your theory sounds great, or your presentation sounds great in theory, but most of us struggle with getting support from our CFO. In practice, has this worked?
Yeah, I can take that one. It's worked. I've done it in 2 or 3 different hospital systems. As I tried to stress in the presentation, it's very important to have your ducks in a row. It may take 3 to 4 to 5 to even 6 months to put all this together, but it's work that's really needed to be able to sell it. FTEs are at a premium. Everybody on this call knows that, and it's important to have that pre-work done if you're going to make this happen. So it's been done. It just takes a lot of work.
Well, and I'll add to that, Patrick. The finance folks, if you haven't noticed, are a bit skeptical, and so all of these savings that I reported, I actually requested an audit by our controller, so that there was no question whatsoever that these were legitimate savings, and so I can attest that yes, that these were real results from implementing this program.
All right, our next question is 2-part. The first part is, where did you start with developing this program? And the second part is, how long did it take before you had the program up and running and realizing the savings?
So I'll start, Pat, and you can jump in as you see fit. But where it starts is, as Pat outlined, in developing the value prop and getting justification for the position. Now, in parallel to that, we started working on cleaning up and organizing and standardizing our data so that when that position was brought on board, we could collaborate with that person and leverage the data that we had. And then the amount of time that it takes is really dependent on how long it takes to recruit and hire that position. What's key to this, and Patrick outlined very well the keys to success, and so you have to have the right person. In one organization where we implemented this program, that person was a former radiology director, and had a lot of knowledge about the technology. In another organization where this is implemented, that person was an extremely talented clinical engineer that was had spent his entire career servicing imaging equipment, but had a knack for developing terrific relationships with the radiologists and other physicians throughout the organization. So we're, as far as how long before we started to see results, I think about 1.5 years. Would you agree, Pat?
Yeah, I was going to add, Al, that that's pretty realistic in trying to go after the position and develop the committee. I've also done it a different way. I've put a committee together when I didn't think I could get a technology assessment director, and you leverage the committee to leverage the position. So once because once you get the committee set up, there's usually a glaring hole there, It's like, man, if we had somebody just to go after technology, right, and really vet out technology, I was able to get a position that way when I probably couldn't have got it, the more conventional way that you talked about. So a couple different ways for everybody to think about it, I think.
Great, thank you both. Our next question is, can you elaborate on what types of capital equipment can be tied directly to reimbursement?
So definitely, procedures that are done, within each one of those groups that you use the equipment with. So a lot of times when we, prior to a technology assessment person, we would have, the director of radiology, the director of OR come in and start to justify their equipment based on volumes, based on what they were going to get paid for, based on, what they saw in the future in terms of growth. And that's how they tried to justify their equipment. Well, many times we had them come back before we had the technology assessment person. We had them come back, and many times they didn't hit those targets in terms of reimbursement, in terms of volumes that they thought they were going to hit. Depending on if it's a DRG basis or if it's just, a cost basis, depending on how your facility sets that up, working with that reimbursement specialist in any of this equipment, and the procedures, performed on that equipment is key. Anything to add, Al?
No, I think that covered it, Pat. And I will add to that that's the same mechanism that we use to determine the cost of downtime. How many procedures do you do per hour, and how much do you get paid for each of those, and then every hour of downtime effectively translates into that loss of revenue.
I would just say like the Da Vinci robots and some of that new technology, there really wasn't a whole lot of reimbursement for that. But the hospitals were being sold on it based on, hey, you can market this, you can be the first on the block, so to speak, to get this technology in your institution. Physicians would demand it, that type of thing. So that's where technology assessment at least can advise. Even though they might get overruled, they can take a deeper dive into it and just prove that there wasn't a whole lot of reimbursement involved at the get-go.
All right, great. Thank you so much, Al and Pat, for your time today and for a great presentation. Al, do you think you could move forward on the slide just so that folks can know how to get in touch with you? Thank you so much. I would like to encourage everyone to visit today's sponsor to learn more about the services they provide to our industry. Please visit accruent.com. As a reminder, you can obtain your CE certificate by completing the post-webinar survey. The survey will be emailed to you 1 hour after the completion of today's webinar. You must complete the survey to receive your continuing education credit. You'll be able to download the certificate once you submit the survey. If you have any questions, you can reach us at webinar@mdpublishing.com. ICE Magazine is proud to bring our new monthly webinar series to the imaging industry. Thank you for being part of the ICE community. For more information about our upcoming ICE webinars, please visit icewebinars.live. Thank you all so much and have a great day.
Thank you, everyone.
Thank you.